Welcome to the Protecting Your Nest podcast. Today, we celebrate the 50th episode of the Protecting Your Nest podcast. It's been quite the journey filled with wonderful guests providing incredible insights and guidance. When I thought about who would be perfectly suited for today's celebratory episode, I knew it had to be someone whose worldview was aligned with not only how I see the world, but consistent with the theme of the podcast. As many of you know, I am convinced that achieving metabolic health is key to preventing many of the chronic diseases that so many people suffer from in the world. For that reason, I wanted today's podcast to feature someone who understands its importance while educating you even further about how achieving metabolic health will help you in areas that may even surprise you. Today's guest is Dr. Gurpreet Padda. Dr. Padda is a board-certified physician in anesthesia, addiction, and interventional pain. For over 20 years, he's practiced in the St. Louis, Missouri area in the U.S. while helping his patients regain their metabolic health. And when your body is trying to get your attention, telling you that something has gone terribly wrong, he believes that pain is that final messenger, a messenger we should all be listening to. So he now spends most of his clinical hours dealing with chronic degenerative diseases that are primarily driven by metabolic syndrome, leading to what he terms meta-inflammation. Today, we will learn more about metabolic syndrome, why it occurs and what aggravates it, and what you can do about it. Dr. Padda, it is my pleasure to welcome you to Protecting Your Nest.
Thank you. I appreciate it.
Dr. Padda, I thought about us and what we had in common, and I reflected. I actually did that this morning, and one of the things that came to mind firstly is that we're both working with the Society of Metabolic Health Practitioners to spread the message of metabolic health and how it can heal via the outreach committee. The second thing I thought about is that we both serve communities that have many social determinants of health-related issues, and we talked briefly about that, and I'm sure you'll touch on that today. Thirdly, we both actually had some time at Cook County Hospital in Chicago. I did some of my rotations there as a student. I remember literally taking the specimens to the lab myself because we were afraid that it would get lost on the journey. So Cook County was a great place to get some training. And the other thing that came to mind this morning is the St. Louis connection. And as you know, both of my sons are at Washington University in St. Louis. So I'll have a senior next year, and I'll also have a second-year master's student. So I'll be having two graduations in 2022. So I'm excited about coming down to your territory to celebrate that. So Dr. Padda, let's get started. And one of the things that I wanted to touch on, since you have this training in pain, is this idea of what is it like to suffer with pain. I've never really had to suffer with pain. I've been very fortunate, and it's just such a horrible way to live. So I wanted to ask you, how did you end up focusing on treating pain as your primary focus as a clinician?
So it was really circuitous. It didn't start off with me going out of medical school going, hey, I want to treat pain. It came with me coming out of medical school wanting to do procedures and be procedurally oriented and going into surgery. And that's where I went to Cook County. I went into the surgery program there and did trauma and all of those wonderful things. And unfortunately, in my first year in the middle, I didn't leave the hospital for about 6 months because there was a nursing strike. And I ended up spending every night in the hospital practically for 6 months. And in that process, when I finally got out and got a chance to get back to my car, there were homeless people living there. And it had been stripped down to nothingness. And the only thing I got out of that car at the end wasn't even a cassette tape. I got the handbrake off my car because the next time I came back, somebody had set fire to it and the whole car was gone. So the reality is that I decided that I loved surgery. I liked the procedural aspect of it, but I also wanted to occasionally leave the hospital. So I looked at my anesthesia colleagues and they seemed to occasionally leave the hospital. Like every third day, they would get to go home. And so I was like, well, maybe I should do that. And I love pharmacology. So I went into anesthesia, ended up going into anesthesia, graduating from Washington University in St. Louis in anesthesia, moving from Chicago to St. Louis. But then I thought, I like procedures still and I like the activity. Maybe I'll do a specialty of anesthesia. So I did pediatric anesthesia, heart, liver, lung transplant, because I'm an adrenaline junkie. And eventually, as I was doing that, I started doing pediatric pain, pediatric oncology, and anesthesia related, and ended up in adult pain. That's been an interesting concept because as I started to look at my adult pain patients, my issue was that there wasn't durability in the treatment. I would look at my patients and go, well, I did this procedure. Technically, this should work. And I get relief. But the patient comes back to me in 3 months, 6 months, 9 months, and it's a durability issue. So I started to question myself, why is there no durability? And as I broadened my horizons to figure out why there's no durability, I started looking at laboratory testing. I started looking at pathways that would be contributing to pain. And that's how I ended up in looking at metabolism and metabolic dysfunction as a primary underlying pathway. At the same time, I also was getting board certified in addiction. And all of a sudden, it occurred to me, hold on, there's this whole neuroinflammatory pathway. And certainly addiction is primarily an issue of exposure to medication and a societal issue of isolation. Because even though you're exposed to medication, you may not necessarily become addicted. It's only in the context of exposure with isolation. And even beyond that, it's a primed brain that requires it. You just don't become addicted because you got a tablet of morphine because you had back surgery. You become addicted because you had a tablet of morphine. You were having an underlying societal issue of isolation on top of a neuroinflammatory milieu. And so that formed my thinking for metabolic inflammation. And as I looked at my biometrics of my patients, I concluded almost all of them were metabolically deficient, and almost all of them were pre-diabetic or diabetic or overweight and on their process too. And so that's how I ended up in this commonality of addiction, obesity, diabetes, and pain, and the commonality being metabolic inflammation. And then from there, I backed out and I said, okay, so what's health? What's the definition of health? And health, according to the Merriam-Webster's dictionary, is called freedom from physical disease or pain. Both. Physical disease or pain. That's health. And if you don't have freedom from pain and physical disease, you're not healthy. Right now, only 12.2% of the US population is healthy. The other 87.8% is metabolically unfit and not healthy. And that's how we got into a conversation through low carb and things of that nature, trying to figure that out. And I specialize in the urban core. I deal with patients that are predominantly in the urban core, and I deal with a lot of minority patients. And so that's what I focused in on, is trying to bring health back to that community.
And first of all, my wife would appreciate your love of pharmacology because she's a pharmacist. My kids they're going to celebrate the fact that you were a WashU graduate. So I'm going to make sure they both know, those two nuggets. So I appreciate that. And I'm listening to this focus on metabolic health. Now, when you say, 12% are healthy, I've heard those stats. And so for anybody listening who doesn't understand why we focus on metabolic health, that one little nugget should clarify why. So many, I literally had, if you just Google metabolic syndrome and you look at the images that come up online, you'll see things like, dementia and cancer and heart attacks and diabetes and essentially all the things that we're dealing with. So I think it's really important that we all focus on metabolic health, which is why I wanted to focus on that today and have you as my guest for my 50th anniversary episode. I also want to say that many of my colleagues who treat pain, tend to be procedural oriented. And even in my earlier training, it seemed that they were kind of managing with medicine, and now it's kind of shifted towards procedures. So you have a slightly different approach. So just comment a little bit about where this pain management field is going and how we shift them towards looking at metabolic health a little.
Yeah, so I think that we're going to have a convergence of events. Right now, we spend 2/3 of our healthcare dollars in the United States on diseases of metabolism, metabolic dysfunction related to diet. It's about $1.5 trillion a year. And at the current rate of expenditure, probably by 2035 to 2050. Well, I mean, first of all, Medicare is going to run out in about 6 years. But by 2035 to 2050, we're going to have a huge problem. That problem is that we're not going to have enough healthy people that are fit enough to even go into the armed forces. We're going to have an issue that 7 out of 10 people right now are rejected from going into the armed forces because they have chronic disease that they can't get in because of diseases of obesity. And by 2035, 9 out of 10 will be rejected. I don't know if you realize this, but in the Iraq and Afghanistan war, the number one reason why somebody was sent home from Afghanistan and Iraq while they were in theater was not because they got shot. It wasn't because they were blown up by an IED. It was because they were overweight and there was a disease of obesity that forced them to immediately come back.
Wow.
And so this is a big
in the
deal.
military.
While in the military. So they already had been screened in and they got worse in the military. And that poses a challenge. Why would you get worse if you're doing all this physical activity? So it's clearly not the physical activity that's the issue. It's because we have a controlled diet study going on. And that controlled diet study says, this is the food you're going to eat. And this is why in the armed forces, in the prison systems, in the nursing homes where we control people's diets, they get progressively worse. And so when we have these real life controlled diet studies that we control what people consume, we get way more data of what we're doing wrong. And in these controlled diets, these people get worse. And so that's kind of the background. Now, why is it from a pain standpoint? Why are we different? Well, it's because I'm dealing with a predominantly urban core population with no durability in treatment. And I have terrible fear that if I don't do something, I'm not really helping my patients. I hired a statistician from George Washington University. I had her come in and she helped us analyze data for us. I already kind of knew the results, but I didn't believe myself because what I did was I looked at essentially a 9 square block area of St. Louis City, North County. We designated it as a specific census area. And we said, okay, if we look in this 9 square block area, what's the population? What percentage do we know have diabetes, hypertension, obesity? We got those demographics. And then we said, what percentage is going to be looking like that in 2035? What's their current cost of care? And what do we expect their cost of care in 2035? This is 9 square blocks. And so what we found was that the rate of obesity or being overweight by 2035 for the African American female population in that census area went to over 99% by 2035. The diabetes rate went to over 80% by 2035. And the end-stage renal disease rate went to over 50%. And of those, 2/3 would go on to dialysis. When you extrapolate back to current dollars, the cost of dialysis is about $60,000 per year. The low end is 45, the high is about 60. When you start extrapolating for cost of medications, it's about $10,000 per patient per year. When you start adding up the numbers for that population, the entire budget for the state of Missouri is spent in 9 square blocks in North St. Louis. And I don't think that we're going to be able to do that. And so going down the medicalization route of trying to treat people with drugs and keeping doing the same thing that we know hasn't worked is not the solution. We need a different solution that incorporates what we know correctly and make those changes. We can't keep going down the road of giving people $10,000 of drugs a year, hoping to get better.
Yeah. I think about the cost of care, and I think about how practical a solution this lifestyle approach is to help not only help patients achieve their goals, but to reduce the cost of care. And I think in the past, we've not been good at sharing the message of the metabolic health message, the message of how it can be treated with lifestyle, and also the message that people will do it if guided by the right information. So I think, you just wish you can shout on the rooftop to those who make decisions, rather in politics or in healthcare for organizations as large as my own, for Advocate Aurora, that we can just make sure they understand that if we focus in this area, we will literally save ourselves and save the country from metabolic disease. So I really appreciate those statistical realities, because I'm just so thankful that we do have an answer. I think there was a time when we didn't think we had an answer other than medication and procedures and surgery. So thank you for that. I do want to, talk a little bit about the contributions of what causes metabolic disease. I've heard you talk about vegetable oil extensively. I've heard you talk about carbs. So just talk a little bit about why those in particular are two areas that can really cause metabolic disease.
Yeah, so I think that the primary issue is that our dietary guidance has been misguided. And so we tell people that it's okay to eat carbohydrates. We let people eat, even diabetics, 100 grams of carbohydrate a day. We tell people to avoid saturated fat from animal products because it's unhealthy. That's what we tell people. And we tell them that vegetable oil is relatively heart healthy, quote, heart healthy. And the problem is that those are the wrong studies. There's a Credit Suisse study that looked at physicians. And if physicians can't get this right, then how do you expect anybody else to get this right? Over 80% of physicians thought that vegetable oil was healthy. Over 80% of physicians thought that the cholesterol that you ate was the cholesterol that they were seeing in the coronary arteries. And this is fundamentally flawed. And if you follow the traditional guidelines, the chances that you're going to lose weight following your nutritional guidelines that are promulgated by our traditional societies is 1 chance in 167 to 1 chance in 220. So the chances that you follow the guidelines that we have that are historic are wrong. So what's wrong with them? Well, what's wrong with them is that the omega-6s in processed seed oil, which is vegetable oil, those omega-6s intercalate into the cell wall. And they intercalate in such a way that they prevent the mobility, the flexibility of the cell wall. And if you don't have flexibility in the cell wall, then the receptors that stick to the cell wall don't work right. And so you can't attach insulin to those receptors because there's no mobility. It also means, though, that the arachidonic acid pathway, the pathway of formation for a lot of inflammatory cytokines, gets triggered because we have defective cellular compounds. And when you get triggered, you get a lot of inflammation. And if you get a lot of inflammation, everything starts to go bad. You overwhelm your system. And that's why if you looked at patients that got COVID-19, the vast majority of them that got really, really sick were in a pre-existing hyperinflammatory state. And when we looked at the studies on this, the vast majority were obese or diabetic. Those are the ones that had significant long-term sequelae. And there's a direct proportionality between visceral fat mass and leptin secretion. Leptin is your satiety hormone. Insulin is your fat storage hormone. You release insulin when your body thinks it's going to get a carbohydrate load, and it converts the carbohydrate into storage. And eventually it ends up as fat storage. Well, the thing is that your fat produces leptin to tell your brain to stop eating. But as you have so much fat, you produce so much leptin that your body desensitizes to that leptin. And then you end up in a circumstance where you have excessive leptin, and leptin is one of the strongest cytokines that we have, and it causes tremendous inflammation. So you get this resistance picture with the omega-6 fatty acids, the vegetable oil, and that causes a cascade of inflammation and inability to interact with the receptor. And at the same time, we're feeding people with tremendous amounts of processed carbohydrates. And specifically, we're feeding them with high fructose corn syrups. And normally, a high fructose corn syrup is a 55-45 ratio, 55% fructose, 45% glucose. But the problem is that the high fructose that we have in our sugar sweetened beverages has been further modified to the point where it's 60%. Now, why would a beverage company spend extra money beyond the subsidy that they get to give you the carbohydrate? Why would they spend extra money to give you extra fructose? There's a real simple answer. The fructose puts you on the hedonic treadmill. It activates your dopaminergic receptor, and it makes it more hyperpalatable and more hyper addictive. And so now you have little kids who have sugar sweetened beverages on top of their processed seed oils, and their brains are just wired to not function correctly, and they consume. They're on this consumption kick. And unfortunately, what started off as an amazing concept of food stamps and food subsidies has turned into a mess. We just have a ton of processed food that you can buy with your food stamps. I think about a quarter. Don't quote me exactly. I think about a quarter of all food stamp consumption is going toward sugar sweetened beverages, which are just empty calories, and that's just a waste for everybody.
Yeah, if anybody does the experiment I do every time I go into Walmart or any grocery store, and you just look at the carts of the people who are in the store with you, and you tend to not see animals and fresh, vegetables. You tend to see the processed food, and there is a correlation. And I don't want to, demonize anybody, but you seem to see a correlation between, what you see in front of you as a person and what you see in a cart. And again, it's not that people want to not feed their kids healthy. I'll see a kid with their parent, and they will be next to all the, what appears to be healthy juice, items and things like that. And it's just, if you read the labels, it'll say things that'll make you assume they're healthy, and they're simply not. So I think we have a lot of work to do. What's really striking about your comments about fructose is when in my University of Western States training for nutrition that I'm working on now, we talked about sucrose and, table sugars, sucrose, and it's 50% glucose and fructose. Well, you would think if it's 50%, how can you just go from 50% to 60% or 55%? It can have such a devastating impact, right? It seems like it wouldn't be that dramatic, but it seems like our body can better tolerate 50-50 versus when you change the ratio. So imagine products that are just 100% fructose. I looked at some barbecue sauce recently. I looked at the label, and it was the first ingredient was fructose. You'd think it would be tomato paste, vinegar, but it was fructose. And imagine how much fructose was added to this product. And it seems so innocent when you put it on a rib. But so we have a lot of work to do, a lot of education to do. And I just want you to touch on that. I also want to be a patient for a moment and just imagine walking into your clinic, and your training has given you some broad perspective and how you approach your patients. And so I want you to give my audience an idea of, when you talk to a patient, what do you tell them? Clearly, you tell them to avoid vegetable oil, but give us a sense of what are the 5 or 6 things you tell patients who are new to you, what protocol or approach you give them so they can be successful as they try to heal from metabolic disease.
So I pick the things that are the easiest for the patient, that are the least invasive first, because you can't hit them with 15 things at once. I find that that's not going to work, and you have to give them successes up front. And so I can't go to a patient and say, tomorrow I want you to stop eating all sugars, or tomorrow I want you to go out and buy high quality protein and this and this and this. It just doesn't happen. We have a wonderful clinic where patients help each other, and they start their own support groups, and they literally help each other. They start One woman started her own chickens. Another gal started growing her own vegetables, and they trade amongst themselves. So there's a communality that we've created, and we work with the African American churches wherever we can because we're in the community. And so we work in those groups. But what I do is I try to figure out the simple stuff first. And the simple stuff is educating people what is a sugar. And I'm always amazed at what people's misperception of what is a sugar. They assume that they have to have their 3 to 5 servings of fruit a day. And in their mind, they're going to get those 3 to 5 servings if it comes in the form of a juice or something else even. And so that's, first thing is we kind of do an education of, well, this is what a carbohydrate is. This is what a sugar is. And the look on their faces when you tell them that fruits are not necessarily healthy, and that cup of grape juice has about the same amount of sugar as that cup of Coca-Cola, that confuses them. So educating people what a carbohydrate is. The next easiest thing to do is to start talking about vegetable oil. See, they've always been demonized that you can't use butter. Butter is a bad thing. And when you tell somebody that they can have real butter, that makes things a little bit more palatable because they like real butter. People like real butter. And if as soon as you get them away from vegetable oil, a lot of their symptoms start to improve, especially their abdominal symptoms, their GI symptoms start to get better, and you get some results there. Those are the first 2 things that we go through. But then after that, we start talking about, well, look, every time you eat, I want you to move. So if you eat a meal or a snack, I want you to start moving 5 to 10 minutes. That means you take a little walk, 5 to 10 minutes. And so it's our step section of our program. So every time you're eating, you're walking 5 to 10 minutes. And then we go to how do we modify their behavior to condense their eating window? And so we use a modified time restricted nutrition. And what we do is, do you like breakfast? And most people well, I eat breakfast because it's healthy. I've always been told it's healthy. And if you tell them, no, it's actually probably not the healthiest meal of the day. It's probably the best meal of the day for the cereal company, but for you, it may not be the best. And if we can avoid setting you on that treadmill of eating carbohydrates in the morning, you may have less total that you eat for the day, and you may be less hungry. And so what we try to do is we push them into a time-restricted nutrition window and let them eat between 11 and 6. And at the same time, we start working on their sleep pattern. Once we've done that, then we start cranking back on the carbohydrates, and we start adding krill oil or fish oil. And so it's about a 7-step process, but we take 1 step at a time, and we do it over the course of time. See, the thing is, if you were to quit smoking, and if I told you, hey, Tony, you got to quit smoking, and you would look at me and go, well, I've tried 7 times and I can't do it. Well, do you know it takes 14 to 21 times to quit smoking? And so you're not going to break off of carbohydrates and crappy food with one conversation. It's going to take a year, and it's going to take repetition, and it's going to take coaching, and it's going to take cajoling, and it's going to take a little push here or there, and it's going to take reward, and it's going to take congratulatory effort. And so that's what's wrong with our medical system. We're not allowed to have a patient come in 14 to 21 times in a year and get that push. And the problem is most of our dietitians are trained by the big food companies. And so they're pushing for processed snacks for these patients. And I'm pushing for no snacks. Right. And so I also intermeld the concept of health equals wealth with my patients. I'm like, look, you're not going to get to function unless you're healthy. But once I get you a little bit healthy, I want you to get to function, and I want you to start making money. I want you to figure out how you're going to be a productive member of society. And I always couch it as, what are you going to do to help other people? See, the second that you make the patient the mentor for somebody else, all of a sudden you change their lives because they're not dependent upon you. They grab that information, they run back to their own church, and they're sharing that information. And they're, and they know that I'm pretty harsh, and they sometimes get really upset at me and call me all kinds of bad names, and that's okay. I usually start off my conversation with, "You're probably going to call me an asshole, but this is what we need to do. This is how we're going to get there, and you're not going to like me in the process, but you're going to like me at the end." See, your normal chances of losing weight is 1 in 167 to 1 in 220. Your chances of losing weight in my clinic are 8 out of 10. And that's a big difference. And that's because I'm not following the standard protocol of move more and eat less. I'm following a protocol that focuses in on your satiety and your inflammation. And so I think that that's the critical difference. And then the reinforcement that's nearly continuous.
Yeah, you remind me of Dr. Eric Westman. He has his page 4, and he just has them to follow the recommendations on page 4, which is basically telling you what you should and shouldn't eat. But what really reminds me of Dr. Eric Westman is this idea of fruit not being a health food. And I think it sounds like you're re-educating. In fact, I think in Dr. Eric Westman's office, he has fruit is nature's sugar or nature's snack food or something in his office. And I think that is important for people to see that, because then they'll fully understand that I've been told something for years that was not evidence-based. It wasn't really science. It was probably more to help food companies to sell their food. So you'll eat breakfast and things like that. So I love all of that. And I like the fact that you keep it simple. I love the fact that you start with vegetable oils, because that's not as addictive and people can kind of get rid of that. They just need the knowledge. And then you work on those other areas. It kind of sounds like my nest, in that you're not just focused on nutrition, you're focusing on all these other aspects of how they think and how they look at life. So that's very important. So I wanted to, go into the fat conversation just a little bit more. Helping people understand, why we get fat in the first place, I think is helpful for them so they can understand how not to get fat. So I want you to kind of explain a little bit of why we get fat. And by the way, I checked your website out in preparation. You have this really cool graph on your website entitled Carbs and Fat, separate storage, so I'll make sure to have a link to that for those who are listening. But I don't know if that graph is kind of speaking to this concept of, why we get fat, but I want you to speak a little bit about why we get fat and maybe comment on that graph as well.
Yeah. So that graph it's actually something that I came up with for myself more than anything, because I was trying to figure out, how do I explain to a patient the whole concept of how is it that this insulin that they're taking is creating fat?
Right.
Because, why is it? And why is it relevant? And so here's what happens. Let's say that I start with somebody who is a perfect healthy specimen. And I say to them, look, I'm going to give you carbohydrate loading, but at the same time, your pancreas is going to release insulin. You're going to store a certain amount of that carbohydrate initially as glycogen store. But your glycogen store is limited. And so it's going to store a couple 100 grams of glycogen. But as you keep eating food with carbohydrates, your body's going to consume it. It's going to take it in, and it's going to overwhelm the glycogen storage. And that's limited to about 500 grams, which is about 2,000 calories of storage. Now, once I get over those 2,000 calories of storage, the next little bit is stored as fat. And if I keep eating, it's stored as fat. Now, in the US culture, our problem is that we never burn down through that glycogen. We're not physically active enough to burn 2,000 kilocalories with nothing coming in on a given day. So every day we wake up with a liver full of glycogen. And the first thing we do is we eat, which then immediately goes to fat storage. And so you have to deplete the glycogen that exists, which is the whole concept of a ketogenic diet, deplete your glycogen, and so you can burn into your fat stores. If you don't deplete that glycogen store, you're not going to do anything. And so that was the essence of it, because you have unlimited fat storage practically, but you have limited glycogen storage. And so it overflows from that narrow little glycogen tube into the massive mountain of fat that you can store. And if every day you start with a full glycogen load that your liver stored from the day before and your muscles have stored, then you got a problem. And that's why we use time restricted nutrition, because the average person in the United States smokes cigarettes, if they smoke, about every 20 to 30 minutes. The average person that's overweight or obese eats every 20 to 30 minutes. They have about, I think on average, about 7 to 14 major food interactions per day where they're consuming. So it works out that it's about the equivalent, the number of feeding cycles is the equivalent of cigarettes per pack. And that's why the cigarettes are designed in such a way with a certain number of cigarettes per day, because you smoke a pack a day. And so that's our feeding interval. That's our addiction interval, is about every 20 minutes or so. Those are the hits that we try to take. And that's the issue. So if you never deplete of glycogen at all, then you're going to just keep stacking and storing. And that's the issue.
I love it. So keto and intermittent fasting help to deplete those glycogen stores. And I would have not believed that stat you just gave about how often people eat until I'm sitting here thinking about when I walk around, and I hope my teams don't hear me, but sometimes I'll see like snacks literally sitting by the computer as they do their work, because a lot of the work they do is on a computer, and literally it's just constant snacking all day.
It's foraging. It's foraging behavior.
It's like literally a cow that's grazing. And what I love about intermittent fasting is that you're simply not hungry. The only thing you'll see by my desk is some water probably, or maybe some coffee or tea. But to imagine doing that all day and what that must feel like. And for anybody who hasn't tried keto or intermittent fasting, you really, once you become adaptive, keto or fat adaptive, you just don't really get hungry for most people, and your mental clarity is sharper and you just feel wonderful. So it's a great experiment to try. And so I appreciate that graph description. And again, I'll have that in the show notes. But you had another graph I thought was cool. And that graph was called Continuum of Type 2 Diabetes Progression. And so in that graph, I assume it's got something to do with insulin, just glancing at it. But, what lesson are you attempting to teach in that graph?
So what that graph tells you is essentially that if you go to your doctor and they do your blood test and they do a hemoglobin A1c, which is the blood test that we use to measure your long-term glucose level. It measures your glucose over the last 120 days or so. And it measures how much glycation, how much stickiness there is on your hemoglobin. It tells you the average sugar over time. If you go to your doctor and they say, hey, your hemoglobin A1c is a little bit high, but we don't think it's high enough to do anything yet. If that hemoglobin A1c is over 5.7, you're in trouble, because your heart disease started actually at 5.4. And 5.7 is significant. And by the time that they want to treat you, which is 6.3 to 6.4, you're well on your way to having significant nerve damage, small vessel damage, kidney damage. And there's actually a recent study that just came out in the last week that shows that the ideal hemoglobin A1c is not 5.7 or below. It's probably 5.4 or 5.2 or below. And I try to get my patients, once I get them recovered, I try to get them down below 5.4. And don't do that with insulin, though. We don't give them more insulin to bring their sugar down. What we do is we reduce their carbohydrate loading so they don't need the insulin. The insulin is actually the issue. The insulin is a pro-inflammatory compound that causes calcium deposition and is probably associated with a whole host of other complications. And it's probably the single biggest reason why we have high blood pressure. That's why it affects the renin-angiotensin system. And that's why we have a major epidemic of hypertension. That's why we have all of these other issues. So I try to, that graph is really intended to show that most of your metabolic damage starts well before most people recognize that you're diabetic. It starts in that pre-diabetes phase. And it's really cheap to fix that pre-diabetes phase, because most of the medications that we use and most of the technology and techniques that we use costs less than 5 cents a day at that early phase. But by the time that your hemoglobin A1c is 6.4 above, you're talking $20 a day to treat. Whereas at the other end, it's like 3-4 cents a day to treat. And so there's a big difference. And why wait till you're 6.4 and have major complications? Why not fix it early?
Yeah. And and for all those listening, Dr. Padda and I are not that special. We were both traditionally trained, and both were probably just fine with people who had hemoglobin A1Cs that we're now finding too high, even at the 5.8 range or 6 points. So we both, that's not too bad. You're doing fine. We're probably those types of docs. So most docs and advanced practice clinicians who practice that way, they just didn't get the memo yet. And so we're trying to help spread the message, not only to those clinicians, but to you as a patient. So if I were you, if I were hearing this message today, I would have a conversation, a collaborative conversation with my clinician. Share this podcast if you have to, and just say, hey, can we order a fasting insulin level just to get a feel for where I'm at? And if that insulin is, or your pancreas is working overtime to maintain your blood sugars, Houston, we have a problem and we need to act on it. And as Dr. Padda has suggested, it's affordable. And for those who are more clinical, I remember learning about the advanced studies and the Accord studies and the VA studies that all showed that, yes, if you tightly controlled the blood sugars with insulin and medication, sure, you'll get the A1C down, and you may reduce the risk for amputations and kidney failure and blindness. But guess what? You're still having heart attacks and strokes. And they had to stop these studies. And they were like, we don't know why. Well, I would argue that we do know why. We know it was an insulin problem. Insulin was being elevated in the name of trying to lower the blood sugars, but you didn't get to the root cause of the problem. So I think we're learning things, we're getting more information. And with that information, we must do things differently. So another thing that I wanted to touch on is this idea of, plants being harmful. And, for many years, we've been told that the only way to save the planet, the only way to improve your health and be healthy is to be plant-based. And I was a vegetarian for 8 years and certainly believe that. But I want you to talk a little bit about in what way are plants harmful and we should be a little cautious about them.
So it's really funny. I was a vegetarian for many years as well. And until I ran into Gates Barbecue in Kansas City. And every day I would watch people go line up to go to this place. And I didn't know what Gates Barbecue was. I'm going to digress for a second because there's some relevance to it. So one day I was in my latter end of medical school, and I've been a vegetarian for years. I haven't eaten a meat product, but I'm smelling this stuff and it smells good. So I walk in there and the woman looks at me and goes, "Hi, may I help you?" And I didn't know what to say because I'd never been there. And she looks at me, she goes, "Virgin," and throws me out of line. It sends me back outside. So then I'm like asking people, well, how does this work? They're like, well, you have to have your order ready and yell it. And if she asks you and you don't yell it, you're getting thrown back out again. So I was like, well, what do you eat? And the guy next to me goes, "I eat a beef on bun." And I'm like, all right, that's what I'm going to get. So I walked in, and just as she's yelling, "How may I help you?" I'm like, "Beef on bun." And she goes, "Okay." And that was my exposure. And I kid you not, I had one bite of that stuff. And I was like, this is the best thing I've ever had in my whole life. And I was no longer a vegetarian at that very moment. I ended up starting a barbecue restaurant eventually that seats 600 people in St. Louis County based upon that. Hendrick's Barbecue. We sold it about 1.5 years ago, but that's the issue. So, as in terms of what's wrong with a pure vegetarian diet, there's a couple things. Certainly there are a lot of patients that are very sensitive to some of the phytates, the oxalates, the phytic acid. There are people that are sensitive to the glutens. They're sensitive to the gliadins. In fact, 28% of all people that are type 1 diabetic actually have celiac, and they have an autoimmune dysfunction with a cross reaction between celiac and the gluten and their own pancreas. So there's some autoimmune issues that are associated with it. There's also a lot of leaky gut associated with a whole host of vegetables. So that's one issue. The current issue is that there's an agenda to push us more and more toward processed food, the Impossible Burger, things of that nature, artificial food that is processed, that's vegetarian. And the methodology behind that thought is that, well, these cows are burping and farting, primarily burping and producing all this CO2. And there's a problem with the concept that they're producing a ton of CO2. I don't think that that's actually accurate. And the reason why it's not actually accurate is that cows, by their very nature, are certainly going to produce methane and they're going to produce carbon dioxide, but they forage on land that we don't really use. And they help reincorporate and create healthier soil. Now, if you have a well-managed system with good foraging, you can actually take more carbon out of the air with foraging than you can any other technology that we have. We could probably set back global warming 20 years, 30 years, if we simply went to healthier soil. And we could probably do that in a few months' time. It wouldn't have to be a super heavy expense. It would cost a lot, but it wouldn't be the cost of what we just spent for COVID. And we could reverse global warming by 20 years by going to a foraging system. So and improving soil health, because that's the largest soil is the largest carbon storage method in the entire world. And we're not really utilizing it. We continue to destroy that. And when we monocrop, when we do single crops that are for processed food, we're only making the soil health worse. And so that's my other issue, is that a lot of times the vegetables that we get are not heirloom vegetables. They're standard vegetables that are specifically engineered. And we use a lot of herbicide and pesticide to grow them. And we bioengineer these things, and we're destroying the soil health while we're doing it. So I also own a farm, and I grew up on a farm. So I'm intimately connected to the soil. I think our farm, we've managed to gain about, I think, 16 or 17 inches of topsoil in 4 years because we have ruminants there. We've got cows and goats, and we have them forage, and we've got pigs also, and they truffle up, and we move them through the farm so that they improve the soil health. And it's created an incredible biodiversity.
And I think for all the people who listen who are concerned about global warming, it's important that you hear this message with clarity. You could clearly make a case for factory farming and how that's probably not an ideal way to raise cattle, clearly. But keep in mind, Impossible Burgers increase the carbon footprint. People think, well, it's a plant-based burger. Well, they increase the carbon footprint. But if you raise cattle properly, as the doctor has suggested, you can not only not do that, but you can improve the carbon footprint. So it's a kind of a no-brainer. And I do believe, from what I've read and seen, that we could make our entire world a world where we do it the right way and have plenty of food for everybody. So I think these are important messages. And I think and it was really funny to hear you talk about that experience at the restaurant. It reminds me of Seinfeld and the soup kitchen and how, you had to get that soup order right. And we have a restaurant that sells Italian beefs. And although I don't eat sandwiches too much anymore, when you go in there, you can't say dipped, you have to say wet. You can't say, hot peppers, you just say hot. It's like a complete language thing. And once you kind of pay attention to what everybody's doing and you do it. If you don't do it right, they won't kick you out, but they will look at you funny when you don't order the food properly. So that's really a cute story. So since you're an addictive specialist, I want to touch a little bit on that. And, I've heard you talk about, addictive behavior is very complex. And you've talked about how having a sense of community and things like that matters. So talk a little bit about why why people have addictive behavior and what types of things you do to approach that.
Yeah. So there's a couple things that you have to understand as necessary precedents before you get to addiction. And so let me give you the studies that were done. So they did a very interesting rat study, and they gave rats an opportunity. They put a rat in a cage, a glass cage, and they gave the rat an opportunity to have regular water, or they could have cocaine water. And the rat went over, tasted the regular water, tasted the cocaine water, hit the bar for the cocaine water, kept drinking the cocaine water till he died. And they said, oh, rats exposed to cocaine die. And that makes sense. Rats exposed to cocaine die. They repeated the study multiple times. They came to the same conclusion. Now, they had an issue with this because during the Vietnam War, we had a lot of service members that were exposed to opium. And people were convinced that when we repatriated these people, the people that were in the war theater, when we repatriated them, the exposure rate was about 60%, 70% maybe, that these people were going to all come back and be addicted to heroin. And it was going to be a problem. And we're going to have walking heroin zombies in our community, 60% of them. And this was going to be a major problem. But what actually happened? People came back and they weren't. Their addiction rate was no higher than the natural addiction rate in our culture, which is at the low end 1% to 2%, at the high end 4%. It was about the same. And so what happened? What happened was that in Vietnam, these people were isolated. They were in a war theater. They were working together collegially, but they were isolated in their own heads. So they did another rat study. And they looked at the rats and they said, okay, look, I'm going to put the rat in the cage. I'm going to offer him cocaine and I'm going to offer him water. But I'm going to put other rats in there to play with them. I'm going to put a complex maze in there. I'm going to have other rats for them to talk to and have sex with and enjoy. And we're going to run the study again. You know what's interesting? None of those rats died. Those rats tasted water. They tasted cocaine. They're like, no, I want to drink the water and I want to play with my friends. So if you look at urban cities, you notice addiction rates that are very significant, and they're there, but you're noticing that these are silos of individuals who overdose because of isolation. Even though they're in a mass of people, they're isolated intellectually, they're isolated socially, they're isolated by the society that we've created, which marginalizes them and prevents them from integration into our economic system. And so that's an isolation that we're creating. And what it is the context of exposure with isolation on the top of a neuroinflammatory response that causes people to overdose. It's not just exposure. I mean, I don't know how many people have had a Tylenol 3 after a dental procedure. They're not all raving heroin addicts.
Right.
The reality is that the majority of people, some of them may use socially, or they may do something stupid, but they don't end up being addicted. The addiction is more than that. It's isolation. It's in the context of their relationship with other people. And that's what you have to fix. So when I deal with my addiction patients, the first thing I do is, and this is why a lot of the 8-step programs work, the isolation programs, the Alcoholics Anonymous, the Narcotics Anonymous, a lot of them work because they're providing that social structure that people are missing. And the problem is that once you've been in the social structure of addiction for a period of time, your language changes and your behavior changes so that you no longer fit the general mold of society. And so you have to reintegrate slowly. And you have to reintegrate in an appropriate way. And so you have to be able to reintegrate people into pods and then integrate the pods into society.
Definitely.
And you have to give them a mission and a purpose.
Yeah. I really appreciate the work you're doing. I think about Dr. Joan Iflin and her Reset community. I think that's a nice resource because it seems like when I talked to her about it recently, she said they have 14 hours of programming throughout the day. And even if you're just listening to it in the background while you're washing, clothes or taking a drive, it creates that sense of community. And it's always available to kind of hold your hand, just like a AAA meeting would. So I could see how that makes a lot of sense. And I think for a lot of people who struggle, without those additional resources, they will absolutely have a hard time. Any comments about hunger? I know Dr. Tro, who we both are familiar with, he focuses on hunger. I've heard other people, Dr. Brett Scher, talk about hunger recently. How do you manage this idea of hunger in those patients you're trying to help?
Yeah, so hunger is the reason why we eat. It's that satiety, and then it's the hedonic substitution of why we eat too much, and so we're substituting things. But hunger is the primary driver of why we eat in the first place, and it's the thing that we want to recognize, and we should recognize it for what it is. It's a signal to our body that we need something, and then how do we deal with that signaling is the important part. It's my belief that satiety and the drivers for satiety is what you use to trick your body into not over consuming. So if I have a giant steak and I'm pretty full, the second I have one bite of ice cream, I have a whole new ice cream stomach, and I'll eat ice cream, but I wouldn't have even thought of it beforehand. And so it's sensory specific satiety that's the key element. And the thing is that if you eat and you're not eating a bunch of sugar and you're not having excursions of insulin up and down and you're not getting hypoglycemic at times and you're not getting those drives to feed or overfeed, then things will stabilize. And the thing is that if you do this correctly and you produce a modicum of ketones, and ketones are produced when your insulin level is low, those ketones themselves will cause satiety. They'll keep you calm. And ketones are an amazing fuel source for your brain. And so that's the fuel source that is your default fuel source. That's a fuel source that we all are supposed to be using almost all the time. And yet most Americans are not in any form of ketosis. And that's really that's our primary fuel source. And this sugar fuel source is relatively novel. It's less than 10,000 years old. It's related to it's related to farming and to grain storage. It's about 10,000 years old. Most of our history, 5 million, 15 million years of history is ketogenic. It's related to having low insulin rather than high insulin.
Cool. Another thing that's happened that we had not had in our society is, when things become popular like keto, you'll start seeing keto products, and some of those products, the ingredients look fine. But as an example, when you look at something like Quest chips, which basically tastes like Doritos, it's 20 grams of protein, not a lot of carbs, right? But man, if you eat those bad boys, they taste like Doritos, and I don't know if that's a good idea because in my case, I want to eat Doritos. So any thoughts on these keto-friendly products and if they're of value, or are there people who should avoid them altogether?
I think they're a transition plan. There are very few absolutes in the world, and the
Yeah.
more absolute you become, more absolutely sure I am that you're going to be wrong. And
Right.
so I think that absolutes are probably not a good idea, but I do believe that there is a probably good role for this stuff, especially as a transition. I love chips myself, but I have the fortune of not having had chips in a long time, as in terms of regular traditional chips, because every time I eat vegetable oil, I know that I've eaten vegetable oil now, and I don't feel well. So once you have a clean diet for a while, I encourage my patients to have a splurge day, and they come back and they're like, "You tricked me. I puked for 4 hours, or I had a sick stomach." I'm like, "Yeah, I wanted you to know what the bad diet was, so I wanted you to have a splurge day to try it out." And that's when you can get a patient to recognize that splurge of ice cream and that splurge of fried chicken with a lot of vegetable oil, what that does to them, they don't want to eat it anymore. Then they know that that's what used to cause it. They just didn't know how bad they felt before, and now they know. And so that makes a big difference. But I do think that ketogenic diet, these processed foods that we're getting, do have a role. but within the context of don't do dirty keto. Don't just consume, vegetable oil because it's a fat and you think that eating more fat is healthy. And it's not necessarily the case. If you consume 6 meals of that stuff a day, you got a problem, and you're going to have a bigger problem than you did before. And so I think what I do is I tell my patients, look, stick to food that you have to make for yourself. Stick to real food. And, I have the issue that in my patient population, it doesn't have a lot of money. My patients don't have a lot of money. So I had to figure out a way for somebody to eat on $3 to $5 a day. Mm-hmm. And so, what are the things that my patients can get that are going to cost them less than $3 to $5 a day, that are going to produce satiety? They're not going to feel hungry, and they can lose their weight, and they have adequate amounts of protein, and that they don't have carbohydrates in them. And so it's things like hamburger patties. It's like chicken. It's like going to the farmer's market. It's like getting eggs. It's like getting your own chicken and having it lay eggs. It's avoid the beer, avoid the other stuff, avoid the sugar sweetened beverages. You'll save money. And I actually have had patients put aside the money that they would have normally spent every day. And not only are they getting skinnier, they're getting a little bit of money. And, then they can physically see it. And I think that little savings account that they create for themselves, that little coffee can of money, tells them that they're on the right track, and their family starts seeing that they're getting skinnier and they're healthier and their brain starts working better. And all of a sudden you've changed that person for life.
I like it's almost like you're giving them a budget, and the budget allows them to see where the money's going. I think about people like Dave Ramsey, who teaches, how to be efficient with your dollars. But I think that's important when you know where the money's going, you see what you're saving, and even the time you spend trying to buy processed foods. You could have probably easily put something in the oven during that same amount of time. Chef Amber in California was my last guest, and she makes a chicken sandwich, but she uses coconut milk and some other things she mixes with it to make a batter for the chicken. She tries to have chicken that's raised a certain way. She also uses kind of a paleo friendly bun, which is probably in the same space of keto. And so she's being very creative, and again, that may be at a price point that's not for everybody, but it's just nice to know that you can do these things and do them well. And we just have to learn these principles. So I appreciate that. And the other thing I wanted to touch on was when you think about your colleagues again who treat pain and procedures, pain meds, I'm sure you do some of the same stuff as you transition people, anti-inflammatories, but now on the horizon in most states is cannabis and medicinal marijuana. And I just want to hear your thoughts about the use of marijuana for pain and anything that we need to be thinking about in that space.
Yeah, so I'm conflicted a little. So here's my, and this is a frank conversation. So I personally don't like marijuana, and I personally don't use marijuana, and I wouldn't. And the reason why is that I have a family history of schizophrenia, and it's triggered by cannabis. And we know that. I mean, we have a short arm on our serotonin that doesn't work right. And so I have a family history, which has been really fortuitous, because I told my son when he was 12, I'm like, don't do marijuana because you're going to end up being schizophrenic. And so that was fortuitous, but it's true. So I'm conflicted. I think that there's a reasonable role for all medicinal substances, and marijuana in the context of addiction is relatively low until we engineer it. And what's happened is that the people that made alcohol addiction went to cigarettes, and then they went from cigarettes to the processed food industry. And the same people are now going from processed food industry toward the marijuana industry. So we didn't historically think that marijuana would be very addictive, but it's being re-engineered to the point where it is going to be addictive, because it is going to activate enough of that dopaminergic receptor, not just the CB, the cannabinoid receptors. There is some value to the stuff, but within the context of relative strength. And I certainly don't want people to be using marijuana all the time. But if you have serious pain, I think it's reasonable. And if it gets you off of all of your other meds, then why not? And I don't think that you're going to be a zombie and you're not going to go out and, we're not going to have that reefer movie play out again that the DEA produced, where, zombies on marijuana would attack women. And so I don't think that that's a reality. But I do think that with the change in our engineering, it's going to be an issue.
Okay, cool. And it's okay. So I'm kind of like you in that I really struggled with marijuana at first. I'm definitely more favorable to it compared to hydrocodone, right? And so if I can get somebody off of hydrocodone using marijuana, big fan. But long term, I don't want myself, my family, or my patients to depend on substances to be healthy when they can just protect their nest, right? So if we do the things that we talk about with the nest, I think that you'll feel just as good. I feel phenomenal just because I'm fasting. So I think that I feel fun. I get a dopamine rush when I'm exercising. So there's things that you can do that will replace those things. And again, I consider that a transition substance as well. So to get you off the strong stuff and then hopefully to help you go to lifestyle. Now, the other thing is this Suboxone. We have within our health system, Suboxone Clinics, and that's kind of another workaround to get people off narcotics. So what role does Suboxone play in the treatment of chronic pain and to get people off chronic meds?
So it has a good role for chronic medication management. It definitely improves because it's a mixed acting agent. And so it does occupy some of that mu receptor. So it does occupy some of the receptor that would give you pain relief, and which is part of the dopaminergic response and the hedonic response, but it occupies it in a partial way so you really don't overdose on it. You can't really occupy all of your receptors, and it has more affinity for the receptor than narcotics do. So it can actually induce a withdrawal effect. So if somebody is high on morphine, you give them Suboxone, you actually can cause an acute withdrawal, kind of like Narcan. And so Suboxone has a role to get somebody off of their narcotics. Now, telling you that it's a partial response also tells you that it's a partial response. It doesn't work as well as we would like for pain. So Suboxone has a role, especially if your primary issue is addiction. But it lacks a role if you have other things. If you have a lot of pain, you may still need an analgesic that works better. Now, my goal is to cut you down on your meds. So my average patient coming into my clinic that's been treated, we don't start people on narcotics. We get them and they're on narcotics. So my average patient comes in on about 275 to 300 milligram morphine equivalent. And that's because, they might be on morphine, or they might be on Oxycontin, or they might be on high dose oxycodone. I can usually get them dosed down to less than 25 milligram morphine equivalent in a matter of 6 weeks. And that's because I use other adjuvants like clonidine. We use other ways to fix their receptors. It's a neurochemistry methodology. So we use baclofen and we use clonidine and other drugs to get them off of their mu agonists, and we use procedures to turn off their pain, and then we get them down as low as we can. The historic problem with pain management has been that we give people high dose narcotics for prolonged periods of time, and their receptors are fully occupied all the time. So the receptors upregulate, which is why you have to give them more drug. That's the problem. So what you want to do is you want to have lower dose drug so that the receptors are sometimes not occupied. So the patient feels themselves. And if they're not occupied all the time, they don't upregulate their receptors, and you can incrementally decrease their dose. But there's going to be some people that need long-term pain management. If you've got 4 blown discs in your back and you have horrendous arthritis and you can't get out of bed without some pain medication, I think it's reasonable to treat you with pain medicine. Whereas it's probably not reasonable to give you 800 milligrams a day of morphine because it probably doesn't work at that dose. And so I think very, very low dose works as long as you can feel the excursion up and down and your receptors aren't overoccupied. I think Suboxone has a role for some patients. There is actually a role for just straight Narcan. And I have a lot of patients that are not even on Suboxone, but they're just on Narcan, which is the antagonist to the mu receptor. And the reason why is that allows their own endogenous morphine, their endogenous endorphins to work better. And so that's another concept. I have a lot of patients that have a diagnosis of fibromyalgia. Fibromyalgia is really insulin resistance. If you've been diagnosed with fibromyalgia, I already know that you have insulin resistance. And one of the treatment options for you is metformin. And that's where we're all headed toward is if you have fibromyalgia, I'm going to get sleep restoration and I'm going to give you metformin to make your brain more sensitive to the insulin. And your fibromyalgia symptoms will go away. Your polyarthralgias go away. Your sleep improves and you get back to function. So that's where that's heading.
We have a lot of great work to do, and it's giving people hope. And I'm excited because that's one of the most challenging diagnoses that us clinicians have to deal with is fibromyalgia. So just knowing that is going to be helpful is really powerful. Just a couple of quick points as we kind of wrap up. I'm thinking about your restaurant. I think about Chef Amber in California, and I know she tries to create a restaurant where they avoid, sugar, dairy, gluten, processed foods. And I know you're in the restaurant business, so and I think you mentioned Hendrix, right? So that seems to be a little bit of a conflict. So talk to me a little bit about how you struggled with this metabolic health idea, being in the restaurant business, and how did you reconcile that?
So I owned 5 restaurants and a microbrewery. And how I reconciled it is I sold all my restaurants because I could not reconcile it. And because it's financially difficult to have real healthy fat that you bring in every time for every meal. And people are not willing to pay in when you have a large format restaurant because we seated 600 people. And so you can't do that in large format in the way that we were. And compete with your neighbors who are using the same vegetable oil for 30 days. And if in their fryer, all they're doing is cleaning the oil and reusing it, it's creating trans fats. I don't want you to have trans fats. And so for me, I have to get that oil out and I want to use real oil. So I'm using duck fat and I'm frying my stuff in duck fat, and then I can't fry it for 30 days like that. I have to change it that night. And so I can't leave that trans fat sitting there at a high temperature. I have to use real olive oil. I have to use real coconut oil. And so that was a big issue. And, until the other problem that I had, this is just straight honesty with you. The other problem that I had is that as a culture, we've gotten to the point that if you look at your food and you look down at your plate, and it doesn't have 2.5 pounds of food on it, you go, I'm being underserved. And you don't need all that food. You probably only will necessarily need about a fifth of what's on your plate. What drives me crazy is these large organizations that serve these giant platters of food. Those platters is what you could feed a family with in the 1960s. And now people are eating that individually. We're overfeeding people. And they don't understand that they don't have to, they don't have to eat till they're gorged. It's the concept of Hari Hachibu. It's a Japanese concept of eat till you're about 80% full. Don't eat till you're so full that you're like, oh, I can't get up out of this table. Right. You probably way overate if that's the case. Hari Hachibu is eat till 8 parts full, 8 out of 10 parts full.
Cool. Yeah, I agree. I even, when I heard Chef Amber talk about using avocado oil. You can, and I think in California, in certain communities, you can get away with that. And her restaurant's definitely, as I think about it, it's more of a cafe kind of place. It's smaller. So she could probably get away with that, because when I looked at images, it was not a big place. So maybe that's how she pulls it off. But I just wanted to get your thoughts on that, because you can't unlearn what you know, right? So once you know things, it's just hard to shake that. So I want to kind of get you to comment a little bit about the privilege we both have of being with Doug Reynolds and Pam Devine, spreading the message of metabolic health, which is what we're doing today through the newly formed outreach committee of the Society of Metabolic Health Practitioners. So I want you to share the reason why you wanted to be part of that committee, and what do you think we can achieve with that committee?
Yeah, so I think the committee's purpose and mission is to bring metabolic health to communities that have not seen it before.
Yeah.
They haven't been paid attention to. And I think that that's the whole purpose. And Doug and Pam have, they've done amazing things to bring people together to create that nexus. And I think that they're really looking forward to how they integrate that into society at large. It's a challenge, because the problem is that the minority communities have been left behind. The inherent smaller communities have been left behind of a lot of this keto messaging and a lot of this health messaging. I also have another thought in this, and that is that they're financially disadvantaged, and because they're financially disadvantaged, they're health disadvantaged,
Mm-hmm.
and they're not getting the same answers as an advantaged community. And it's why we have all of these. We have these amazing hospitals that are super expensive and super wealthy and super cool with all of the best technology, but none of them are in the truly impoverished areas of town.
Mm-hmm.
They're always standing apart, and they're ivory towers, and they get their diseases from the impoverished communities, because that's where the disease is. But the hospitals themselves are these fortresses of ivory.
Mm-hmm.
And I see that everywhere. And what we need to do is we need to reconnect to these communities. And I think that what low carb is doing will help those communities reconnect, because what they're going to do is they're going to empower and educate the clinicians in the front line
Mm-hmm.
in those communities to make a difference, to keep the patient from ending up with a disease process that gets them to the ivory tower. We don't want them to go to the ivory tower. We want to get them healthy where they're at.
That's right. I love it. And I plan to ask Pam Devine to join me on an episode of the podcast, just to talk a little bit about her journey, how she got to the point where they're both working to share this message, and just kind of celebrate the work they're doing. So look forward to that. And for you, I want to just kind of think about your journey over the next year, and as it relates to the nest and rope mnemonic or acronym, and are you going to focus more on any of these aspects more than the others? And that would be nutrition, exercise, less stress, more sleep, how we think, avoiding trauma, working on the relationships, organisms that we avoid, pollutants that we avoid, and protecting our emotions and life experiences. So for you, Dr. Padda, where do you plan on giving a little extra love and attention to in your future year?
So inside this, we have very similar methodology. The nest and rope acronym, those fundamental elements are very similar to what I do anyway. But inside that, I'm really looking at using autophagy and trying to experiment with that. I'm a constant experimenter on myself, such to the point where I'll do really stupid things and get myself in trouble. For example, I decided that I was going to do an experiment on hyperthermia and put myself into a sauna. I monitored my EKG, and I was measuring the salt on my skin, and I was collecting samples of it to run later. And I was timing myself, and I was also collecting blood samples of insulin and glucagon. And so here I am doing this in a sauna, and I got so hot that I ended up putting myself into bigeminy. And I was like, oh no. And I could see it on the EKG. I was like, uh-oh, I'm in trouble. And so I shocked myself out of it by jumping into a cold plunge. And that immediately shifted everything. I was like, oh man, I got to be careful. But you end up doing stupid things as a physician that knows too much, and you end up experimenting at the edges. But what I really am looking forward to is understanding a little bit. I love hormesis. That which doesn't kill you only makes you stronger. Um, but autophagy is where I want to play with next, and looking at prolonged periods of fasting, which I know may seem strange, but I think that there's a real value. I don't think you have to fast for 40 days, but I do think that there's an incredible value somewhere over 24 hours and somewhere less than 72. I think there's a real value to it if you're metabolically healthy. And I think that that's something that I'm playing with more. As in terms of other things, autophagy, cellular regeneration, hormesis are all interconnected for me. And so that's where I'm looking more at. I used to rest a lot less. I used to have a lot less sleep, and now I have a lot more, much more than I ever thought that I needed. And it seems to make my brain clearer. And what I'm doing is I've shifted my schedule. So I get up earlier in the morning, but it also means I go to bed earlier. But it gives me those couple of hours to really think and do, and be creative and ask myself to do things that are necessary at that time.
Nice. Definitely appreciate the sleep concept. It's been a gift, and there are times when you can't get it, but man, when I get that sleep, and on the weekends, I just try not to even set the alarm and just see what my body wants. So, and yes, guys, I want you guys to experiment and be aggressive, but watch what the doctor said. We don't want anybody going into bigeminy when your heart, goes into a slightly abnormal beat and you get in some premature contractions, and we don't want any of that. So I appreciate your courage, but
Yeah,
we
it was
want to be
stupid.
safe. That is so funny. So, so in terms of people finding those resources, I will be sharing those graphs, but you have websites. So explain where people can find you and any final thoughts you'd like to share.
Yeah, so probably the easiest way for this topic is probably just our website, reversediabetes.md, www.reversediabetes.md. And that has a ton of resources on it and infographics. And I think there's an Instagram page that goes along with it that also has a ton of infographics. And if anybody has any questions, we're always happy to answer. And our goal is to serve our community. Our goal is to pull us all forward. And so, we decided a long time ago that this was fundamental to improving the health of our community. And so I'm always available to answer questions.
Absolutely. I hope to continue to learn from you myself, and I'll share what I have to share with you as well, since as I mentioned earlier, have a lot in common. I definitely appreciate you being here. And this will be one of my longest episodes, but that was intentional because I felt like let's celebrate with a longer episode and let's bring somebody who I think really could share the right message. So I hope everybody enjoyed you today. And I want to thank you again for just being here with me today.
Yeah, thank you. I appreciate it.
Absolutely. So today, guys, we learned from Dr. Padda that, all pain docs are not the same. Some have additional training in addiction and metabolic health. And I'm just so thankful that he has given his patients for over 20 years this knowledge. And now you have benefited as well as I. And I really think the rationale for achieving metabolic health should be a little clearer today. Today, we learn not only how to treat pain, but what really causes pain. And things like carbs and synthetic vegetable oils, who'd have thought, right? Today, we even learned that loneliness, believe it or not, could impact the chances that you or your family member could be at risk for addictive behaviors, and that fructose is something we should avoid as much as possible. So as we wrap up this episode, I hope that each and every one of you continue to use continuous learning as your primary tool to achieve optimal health. And I only promise that I will continue to help you moving forward, as we hopefully will have 50 more episodes of the Protecting Your Nest podcast. So I thank you. I appreciate you. And until we meet again, be safe, be well, and continue to protect your nest.